Medication non-adherence in chronic disease is one of the most stubborn problems in modern medicine. The WHO estimates that in high-income countries, only about half of patients with long-term conditions like hypertension, diabetes, and asthma actually take their medicines as prescribed. That gap translates directly into preventable strokes, hospitalizations, and ballooning healthcare costs. Enter telepharmacy, pharmacist-led care delivered remotely by telephone, video call, or digital app. Since the COVID-19 pandemic accelerated remote care worldwide, many health systems are now asking, should we make this permanent? And more importantly, does it actually work? This Cochrane systematic review from 2026 takes the most rigorous look yet at that question. The review pooled 21 randomized controlled trials, 17 individually randomized, and 4 cluster-RCTs, covering a total of 5,440 participants. Studies came from high, upper middle, and lower middle income countries, spanning hospital clinics, community pharmacies, and insurer-based settings. The main conditions targeted were hypertension, diabetes, and asthma. Telepharmacy interventions were diverse, ranging from a monthly phone check-in to daily app-based medication tracking, and follow-up ranged from 1 to 18 months, with most studies under 12 months. Primary outcomes were medication adherence, patient satisfaction, and drug-related problems. Key secondary outcomes included blood pressure, HbA1c, quality of life, and healthcare utilization. All evidence was graded using the GRADE framework, and meta-analyses used random effects models. Let's go through the numbers that matter. For medication adherence, telepharmacy showed a statistically significant improvement over usual care, a standardized mean difference of 0.32, which translates to a small to moderate effect size. That's based on 10 studies with nearly 3,000 participants, but the certainty is rated low, so interpret with care. The standout result is blood pressure. Systolic blood pressure fell by about 6.8 mmHg and diastolic by 2.5 mmHg compared with usual care. Both findings reached statistical significance across 5 studies with over 1,200 participants. Again, low certainty, but clinically notable numbers. Now for the counterpoint, HbA1c. 5 studies with over 1,700 diabetic participants showed essentially no effect, a mean difference of just minus 0.10%, with a confidence interval that spans 0. That's moderate certainty evidence of little or no benefit. Patient satisfaction, LDL cholesterol, quality of life, hospital admissions, and emergency visits, none showed meaningful differences. And mortality data? Simply not reported in any included study. We have no safety signal, positive or negative. The blood pressure finding deserves the most attention. A systolic reduction of roughly 7 mmHg is not a trivial number. Population-level data suggest that kind of drop could correspond to a 10 to 15% reduction in stroke risk and around 5 to 10% less cardiovascular mortality. If improved medication adherence is partially mediating this, which is mechanistically plausible, then there's a coherent story here. But the absent HbA1c effect is equally instructive. Blood glucose in diabetes is sensitive to diet, physical activity, stress, and many variables that a remote pharmacist cannot directly influence. Adherence improving but HbA1c not moving is actually something experienced clinicians recognize. It reflects the multifactorial nature of glycemic control. The low-grade certainty on most outcomes means we're not in a position to rule out chance, bias, or the specific mix of interventions driving these results. The effect estimates are real enough to take seriously, but not robust enough to act on universally. The single biggest clinical limitation here is intervention heterogeneity. The label telepharmacy covers everything from one monthly phone call to daily digital engagement with medication reminders and video monitoring. Pooling these into a single analysis gives us a direction of effect, but tells us almost nothing about which specific model works for which patient and at what intensity. That's a critical gap for implementation. Follow-up is too short. Most studies under 12 months for diseases that require lifelong management. We simply cannot know whether short-term adherence gains persist or translate into hard outcomes over years. The absence of any mortality or serious adverse event data is a genuine safety blind spot, and the near total lack of equity-related data on digital literacy, socioeconomic status, or connectivity means we cannot assess whether telepharmacy narrows or widens disparities. For older patients with low digital literacy or those in areas with poor connectivity, the intervention as studied may not generalize. Where does this leave us in practice? The most defensible application right now is as a complementary support tool for hypertensive patients who face real access barriers, people in rural or remote areas, those with mobility issues, or those whose work schedules make regular clinic visits genuinely difficult. The approximately 7 millimeter Hg systolic improvement rivals what you might get from dose titration or adding a medication class. That's worth considering. For patients with diabetes, telepharmacy-driven improvements in adherence still have value as part of a long-term complication prevention strategy, even if HbA1c doesn't move immediately. But it needs to sit within a coordinated team approach involving physicians, dietitians, and diabetes educators. Don't expect remote pharmacist support alone to shift glycemic control. When you introduce this to patients, be explicit. Telepharmacy supports medication habit maintenance. It does not replace in-person clinical assessment or urgent evaluation. Telepharmacy shows real promise for blood pressure management and medication adherence support in ambulatory NCD care. The blood pressure signal, in particular, has clinical weight, but the evidence certainty is still low. The intervention landscape is too heterogeneous to make specific recommendations, long-term outcomes remain unknown, and safety is uncharacterized. Right now, the appropriate stance is use it selectively and thoughtfully, especially for hypertensive patients with access barriers, but don't mandate it uniformly. The field needs longer trials, standardized measures, hard clinical endpoints, and equity-focused analyses before we can go further. This Cochrane review is the most comprehensive synthesis we have on telepharmacy for chronic disease management, and it's an important step forward. But it's also a reminder that promising signals and robust evidence are not the same thing. If you're building remote pharmacist programs in your institution, this review supports cautious optimism, not blanket rollout. For clinicians wondering whether to refer a patient to a telepharmacy service, start with the patient who has access barriers and uncontrolled hypertension. That's where the evidence is strongest. Thanks for watching. If you found this useful, subscribe for more evidence-based clinical reviews.